If you have been prescribed a statin, or if your doctor has just told you your cholesterol is too high, and that conversation is coming, there is something you almost certainly were not told in that appointment. Not because your doctor was keeping it from you, but because the appointment was 12 minutes long. The prescription was the path of least resistance. And what I am about to walk you through requires more time and more honesty than most clinical consultations allow. There is a specific way of eating, not a fad, not a supplement, not something you would find on a wellness influencer's page that has been studied in rigorous clinical trials and shown to reduce LDL cholesterol by amounts that, in the right person, are competitive with a starting dose of statin medication. The mechanism is well understood, the evidence is peer-reviewed, and the vast majority of patients sitting with a new cholesterol result in their hand have never been shown it. I also want to be equally honest about the other side of this, because statins are among the most studied medications in the history of pharmacology. The evidence for their cardiovascular benefit in the right patients is genuinely difficult to argue with. And the conversation that most people actually need, the one that distinguishes who genuinely needs a statin from, who might achieve the same result through diet alone, is almost never had properly. My goal in this video is to have that conversation with you properly, so that you leave understanding both what statins are actually doing at a biological level, what the dietary evidence actually shows, and most importantly, how to think about which one is right for your specific situation. Hi, my name is Dr. Miles, emergency medicine physician with 13 years of frontline clinical experience. I have watched the downstream consequences of uncontrolled cardiovascular disease, the heart attacks, the strokes, the heart failure arrive in my department as the end result of a disease process that was either undertreated or treated in a way that never addressed the underlying biology. This video is about making sure you have the full picture, what cholesterol actually is, and why the standard explanation is wrong. Before we can compare treatments, we need to correct a fundamental misunderstanding that most people carry about cholesterol, because it shapes everything that follows. Cholesterol is not a poison. It is not a waste product. It is an essential molecule that your body manufactures deliberately and continuously in your liver, in virtually every cell, because it is required for the structural integrity of cell membranes, for the synthesis of steroid hormones, including estrogen and testosterone, for the production of vitamin D, and for the manufacture of bile acids that allow you to digest fat. Your body produces between 70 and 80% of the cholesterol in your bloodstream, regardless of what you eat. Dietary cholesterol contributes the remainder. The reason cholesterol became associated with cardiovascular disease is not that the molecule itself is dangerous. It is that specific cholesterol-carrying particles, LDL particles, and particularly small, dense LDL particles, can penetrate damaged arterial walls, become trapped in the arterial intima, and initiate the inflammatory cascade that produces atherosclerotic plaque. It is the interaction between a damaged, inflamed arterial wall and specific LDL particles that drives cardiovascular disease, not cholesterol in isolation. This distinction matters enormously for how we think about treatment, because a treatment that lowers the LDL number on your blood test without addressing arterial inflammation or changing the size and quality of LDL particles may be doing less than it appears. And a treatment that improves the entire cardiovascular risk profile, reducing inflammation, improving LDL particle quality, raising HDL, lowering triglycerides, addressing insulin resistance may be doing more than a single number suggests. What a statin is actually doing. Let me explain the statin mechanism clearly, because most patients on statins do not know it. Your liver manufactures cholesterol through a multi-step biochemical pathway. The rate-limiting step in that pathway, the step that controls how much cholesterol the liver produces, is catalyzed by an enzyme called HMG-CoA reductase. Statins work by inhibiting that enzyme. They partially block the liver's cholesterol production line. The liver, now producing less cholesterol internally, responds by upregulating the number of LDL receptors on its surface receptors that pull LDL particles out of the bloodstream for processing. The result is a reduction in circulating LDL levels. Most statins at standard doses reduce LDL cholesterol by somewhere between 30 and 50%, depending on the specific drug and dose. High-intensity statins, atorvastatin at 40 to 80 milligrams, rosuvastatin at 20 to 40 milligrams, can reduce LDL by 50% or more. The cardiovascular benefit of statins is real, and it is substantial in the right patients. In people with established cardiovascular disease, those who have already had a heart attack or stroke, or who have confirmed significant atherosclerosis, statins reduce the risk of a subsequent major cardiovascular event by approximately 25 to 35% relative risk reduction. This is a meaningful effect, and it has been demonstrated across multiple large randomized controlled trials. For people in this category, the evidence for statin use is strong enough that it is difficult to argue against it on clinical grounds. Where the picture becomes more nuanced is in primary prevention, people who have elevated cholesterol but no established cardiovascular disease. In this group, the absolute risk reduction from statins is considerably smaller because the baseline risk is lower. And this is where the question of whether dietary intervention might achieve comparable or superior results becomes clinically relevant. What statins do not do, to be clear, is reduce arterial inflammation directly. They do not improve insulin resistance. They do not raise HDL meaningfully. They do not change the dietary pattern that may be producing the elevated LDL and triglycerides in the first place. They manage one part of the cardiovascular risk equation, while the upstream drivers of that risk continue unchanged. If this is giving you a more complete picture of the cholesterol conversation than you have had before, please subscribe to this channel right now. This is exactly the kind of information I built this channel to provide the conversation the appointment did not have time for. Every subscription helps this reach further. Hit the button and let's keep going. What diet can actually do to cholesterol? The evidence. Now let me be specific about the dietary evidence, because this is where most patients have been given either nothing at all or the same vague advice to eat less saturated fat that has been recycled since the 1970s without adequate nuance. The dietary approach with the strongest evidence for LDL reduction is a portfolio diet, a term coined from clinical research at the University of Toronto. The portfolio diet combines 4 specific dietary components that each have independent cholesterol-lowering mechanisms. Viscous soluble fiber from oats, barley, and psyllium. Plant sterols from fortified foods, or naturally occurring in vegetables and nuts. Soy protein, and tree nuts. A landmark study published in the Journal of the American Medical Association found that the full portfolio diet reduced LDL cholesterol by approximately 29%, comparable to a first-generation statin at a low dose. A subsequent study comparing the portfolio diet directly to a low saturated fat diet found it reduced LDL 3 times more effectively. The mechanism of soluble fiber is worth understanding because it is elegant and specific. Soluble fiber forms a gel in the digestive tract that binds bile acids, the cholesterol-derived compounds the liver produces, to emulsify dietary fat. Normally, those bile acids are reabsorbed in the small intestine and recycled. When they are bound by soluble fiber and excreted instead, the liver has to manufacture new bile acids. To do so, it pulls more LDL cholesterol from the bloodstream. Soluble fiber lowers LDL, not by blocking the liver's production, but by increasing its consumption of circulating LDL. Plant sterols and stanols are structurally similar to cholesterol and compete with it for absorption in the intestine. Consumed consistently at adequate doses, approximately 2 grams per day, they reduce LDL by a further 8 to 10% through this competitive absorption mechanism. The Mediterranean dietary pattern has a broader body of evidence behind it than any other dietary approach in cardiovascular medicine. The PREDIMED trial, a large Spanish randomized controlled trial, found that a Mediterranean diet supplemented with extra virgin olive oil or mixed nuts reduced major cardiovascular events by approximately 30% compared to a control low-fat diet. Not just cholesterol numbers, actual cardiovascular events. The effect size was significant enough that the trial was stopped early on ethical grounds because it was considered inappropriate to continue denying the control group the intervention. That is a remarkable result for a dietary intervention. Beyond LDL, specifically, dietary approaches that reduce refined carbohydrate and sugar intake, including low carbohydrate and Mediterranean patterns, produce significant reductions in triglycerides and increases in HDL cholesterol. These changes reflect improvements in the broader metabolic picture: insulin sensitivity, hepatic fat metabolism, inflammatory status that statins do not address. And in individuals whose elevated LDL is accompanied by high triglycerides and low HDL, the lipid pattern most associated with insulin resistance, dietary intervention that addresses the metabolic root often produces more comprehensive cardiovascular benefit than LDL reduction alone. The honest comparison. Here's where I want to be precise, because this question does not have a single clean answer, and anyone who tells you otherwise is oversimplifying. For people with established cardiovascular disease or with genetic conditions that cause very high LDL, particularly familial hypercholesterolemia, statins are not optional. The cardiovascular benefit in these populations is established beyond reasonable clinical doubt. Dietary intervention in these patients is valuable and should absolutely be pursued, but it is not a replacement for medication. It is complementary to it. For people in primary prevention with elevated cholesterol, no established cardiovascular disease, and overall cardiovascular risk that is moderate rather than high, the picture is genuinely more nuanced. In these individuals, a committed, sustained dietary intervention using portfolio diet principles combined with a Mediterranean eating pattern can achieve LDL reductions that overlap with low-dose statin therapy while simultaneously improving triglycerides, raising HDL, reducing inflammation, and addressing insulin resistance. The dietary approach in this group does more things to the cardiovascular risk profile than a statin does, and it does them without the side effect profile that causes a significant proportion of patients to discontinue their medication. The critical question to ask your doctor is not simply whether your LDL is high, it is what your overall cardiovascular risk is, calculated using a validated risk tool that accounts for your age, sex, blood pressure, smoking status, and other factors. Because LDL in isolation does not determine treatment decisions, risk does. And for many people in the low to moderate risk category, a structured dietary intervention trialed for 3 to 6 months with repeat blood testing to measure the response is a clinically legitimate first approach before medication is initiated. What to do with this information? The conversation I want you to have with your doctor is this. Ask what your 10-year cardiovascular risk is, calculated formally. Ask whether a dietary intervention trial before initiating medication is appropriate for your risk level. Ask specifically about the portfolio diet and Mediterranean dietary approaches, and whether the evidence supports trying them in your case. And if you are already on a statin, understand that dietary change does not replace it, it works alongside it, potentially allowing lower doses over time under supervision. Do not stop your statin without medical supervision. The rebound in cardiovascular risk from abrupt discontinuation in high-risk patients is real and it is documented. That is not a disclaimer. It is clinical reality. But do understand that the food you eat and the medication you take are not alternatives. In the right person, at the right risk level, done consistently enough, food can do what a starting dose of medication does, and it does it while improving the entire metabolic environment that drives cardiovascular risk, not just one number on a blood test. That is what most patients were never given 12 minutes to hear. If this video gave you a framework for a conversation with your doctor that you did not have before, please subscribe to this channel and share it with someone who was handed a prescription and never fully understood why. Thank you for watching.